This is what a healthy hip looks like. And this is what a hip that's lost some cartilage looks like. And the x-ray will show narrowing of that joint space. There won't be space between the surfaces, and frequently it's bone on bone. Sometimes the femoral head is eroded and flattened, and you'll see cysts in the bone. It just depends on the magnitude of the amount of joint destruction. Again, we start out with non-surgical techniques like we talked about earlier. When that doesn't work, we talk about surgery. Arthroscopy in hips, not helpful for arthritis. Helpful maybe if you have a labral tear and you're a younger individual and there's no joint surface damage in the joint. You can have pain from a labral tear. That's a cartilage lip that the ligaments are attached to on the margin of the joint surface, or impingement. Sometimes there's an impingement there too that you can help arthroscopically. That's for people that don't have arthritis, but we'll identify those people and get them to the right person to do that if they need that. Biologics, I don't think serve a role in hips. Haven't seen them be helpful. Resurfacing is another type of surgery. It's instead of a hip replacement, it's called resurfacing, and it was designed so that you removed less bone, but you still had to put an artificial metal surface in the socket or the acetabulum, and you had to cut some of the femoral head away and put a new surface there with a smaller stem. But the surgery actually was a bigger operation than a more contemporary modern hip replacement. It was a bigger incision, much more dissection, more blood loss, and actually a higher failure rate. And the amount of bone you're saving is, I think, insignificant. It's not bone that's important. So that has fallen out of favor. Partial hip replacements is just replacing one side, usually the femoral side or the ball, the head. And that's done for hip fractures. And you'll see that sometimes. Sometimes those can become painful, and we have to convert them, though, to a complete hip replacement where we resurface both sides. So again, who should consider surgery, or when should you consider surgery? Again, when we've talked about that, when things are bad enough and nothing else is working. So this is a picture of an implant inside the bone. This is the acetabulum or socket inside the pelvis. It's made out of titanium or a similar metal. It has a liner, which is polyethylene, very durable cross-linked polyethylene that has great wear characteristics. And then the head, which will be either metal or ceramic. It's attached to a stem that's fitted into the canal of the bone. And again, it's a porous surface metal that your bone integrates with. So in hips, we tend not to use any cement. In knees, I didn't mention that, but in knees, we'll use a little cement to fix the implant to the bone. It statistically works great. You can do a non-cemented design for a knee too, but in my experience, they've had more problems. And so the gold standard is still using cement for knee replacements, but not cement for hip replacements. Again, the same risks apply that we talked about with knee surgery. And we use aspirin for those as well. So if some of you have done your research, you'll find that there's essentially two ways to do a hip. One is anterior, the other is posterior. The anterior hip is done through the front. It was more recently popularized, and it was advocated because supposedly you can get out of the hospital a little quicker and have fewer restrictions. The posterior incision is just posterior to the greater trochanter. It's about the same size, and it works very well also. My preference is a posterior hip. If you look at the statistics, the risk of complications is generally higher in anterior hips. There's the lateral femorocutaneous nerve that gets frequently damaged, and people have paresthesias or pain over that nerve distribution. You've got neurovascular structures that are a little closer to where your incision is. And if you have an intraoperative problem, like say when you're putting that implant in, which goes very tightly into that femoral canal, if you have a fracture, it's a little hard to address and deal with through this approach. How we deal with it is we put a cable around it, the bone, and a tight cable so that that crack doesn't extend, and you can still, have a solid fit of your implant. So you have to fix a fracture if it occurs, and it's more difficult with this approach in my experience, where a posterior approach has easier access to do that. The important thing is really how that hip behaves down the road. Is it durable? Did you get the best fit possible? Did you get the right orientation? Is it not going to loosen? and because that is really what you want, because the recovery is very similar to both. An anterior hip might get out of the hospital a few hours quicker, but not always. Uh, uh, and again, the precautions for a posterior hip aren't that much more than an anterior hip. Basically, we don't have you bend over and tie your shoes for 6 weeks, but then there are no restrictions after that. And some people don't even adhere to that restriction for their surgery. So the design of the implants have improved this. The other issue regarding this anterior versus posterior, they said anteriors were less likely to dislocate. The dislocation rate for both of these is extremely low, and I don't know that it's statistically different at this point in time with the contemporary hips that we're doing. For instance, my own hip, I had a posterior hip. I couldn't very well go have an anterior hip if I advocate a posterior incision. So I had mine done, small incision, it's tiny, was out of the hospital in less than a day and back to work somewhere around 2 to 3 weeks. So they both work great.